we often get the question, what causes fibroids?
So Sandra, that's an excellent question. And I think it's been researched a lot. Obviously, this is a very common problem throughout the world. And it's been researched a lot, but there isn't a clear answer on what causes uterine fibroids. It usually has nothing to do with, the the lifestyle of a woman. It tends to be more genetic. So it tends to occur in families. So a grandmother will have it, or the mother will have it, their child will have it, their daughter will have it. And it tends to be clustered in families. So there's a very large genetic component to it. It's not very clear if there's certain type of foods or certain type of chemicals that we're exposed to just in our daily life that may be leading to fibroids. But what is very clear that there's a very strong genetic component to it.
Okay, great. So how are uterine fibroids diagnosed?
So the most common way so again, uterine fibroids are very common. So almost 80% of women of childbearing age will have uterine fibroids. And it's even more common in African-American women. Up to 90% or more of African-American women will have uterine fibroids. The vast majority of uterine fibroids are asymptomatic, meaning a woman with fibroids will not know that it exists, or the symptoms may be subtle, etc. But a lot of women will also experience common symptoms such as bleeding, pain, increased urination, etc., which we can talk a little bit more. But with these symptoms, women will go to their gynecologist, and a good gynecologist like Dr. Walker, I've known Dr. Walker for quite some time now, and she's an excellent gynecologist. And she's also very good at diagnosing uterine fibroids because she understands, the symptoms that are associated with it. So
we've already
number
got
one
a couple of questions asking for her information because the lady's already saying, I think she's great.
She really is. I've known her for a long time, and she's really a wonderful human being and a great person to work with. So, you need someone to recognize the symptoms that are associated with uterine fibroids, like, a gynecologist like Dr. Walker. And then the next step is to do an imaging study. So the most common imaging study ordered to evaluate for uterine fibroids is an ultrasound. Just like the ultrasound women get when they're pregnant, it's a very similar type of ultrasound that they get to evaluate for uterine fibroids. And ultrasound is actually a very good study to visualize uterine fibroids and be able to measure them and also locate them within the uterus.
Thank you so much for that. Now, also, we talked about the symptoms and you talked about them being common. So how are uterine fibroids treated? And what are the various different options?
Sure. So actually, before I move on to that, let me just touch a little bit more on the symptoms.
Okay, great.
So again, so bleeding. So the most common symptom associated with uterine fibroids is bleeding. I've had patients who have bled so much that they actually became anemic. And that's a very difficult situation. There are women out there who bleed, 3 weeks out of the month, and those are the women that tend to, have a little bit more tendency to become anemic because they're bleeding so often. So bleeding, because the uterine fibroids are so vascular, that's actually the most common symptom. And again, there are the other symptoms that are associated with uterine fibroids are related to, for example, their size. So those are called quote unquote bulk symptoms. So patients can have pelvic pain, discomfort. The fibroids can press against the bowel or the bladder, causing frequent urination or constipation. There's also, some uterine fibroids can get very large. I've seen fibroids that are 15, 20 centimeters, and it actually feels like or looks like the woman is pregnant because it's protruding out and causing, that much what we call bulk symptoms or mass effect. And then some women, they're diagnosed with uterine fibroids because they're trying to get pregnant and they're not successful or they're having difficulty, and they go to see their gynecologist and they find out that the reason that they're having these fertility issues is because of uterine fibroids. So again, these are the most common symptoms that women usually present with. And the treatment options are basically a spectrum, I would say. So this slide actually lays out that spectrum from the least invasive to the most invasive options. Starting from the left, you can see that some people believe that there's certain types of diets or foods that you can eat to treat uterine fibroids. And unfortunately, that data just has not panned out. So there has been a lot of studies done on trying to figure out if there are certain types of diet that can help with uterine fibroids, and it's just not very clear, and the data is just not very convincing. Another option is hormonal. So this is something that Dr. Walker touched on briefly. She mentioned Depo or Lupron. So this is essentially a medical way to induce menopause. So that changes your hormonal levels, and that can also lead to shrinking of the fibroids. But again, like Dr. Walker was saying, it is a dramatic change because you're taking a medicine that's essentially inducing menopause. And it's also, you can't take it forever. You can only take it for a certain period of time. And it also has some of the side effects that she mentioned, like osteoporosis. On the other side of the spectrum, you have some of these surgical options, such as open or laparoscopic hysterectomy, which is taking out the entire uterus, as well as laparoscopic, open, and hysteroscopic myomectomy. Myomectomy essentially means that you're going in and shaving out some of the fibroids that you can easily target. The challenging thing about myomectomy is that, you can't target all the fibroids. If there are multiple, you can only target some of them. And again, like Dr. Walker mentioned, women who are trying to preserve their fertility, it also limits some of the options that they have when they are trying to deliver the baby. For example, they might not be able to undergo a natural delivery and may need a hysterectomy. Most often will need a hysterectomy. Will most likely need a C-section. A hysterectomy is obviously taking out the entire uterus, and the fibroid embolization is a minimally invasive option where the goal is essentially to decrease the blood supply to the fibroid in order to shrink the fibroids.
Okay, well, very good. Now, what is the UFE treatment?
Sure. So let me show you another slide to demonstrate what the fibroembolization procedure looks like and how it compares to a hysterectomy.
Okay.
So hysterectomy, again, is an open surgery versus uterine fibroembolization, which is a minimally invasive procedure done through the wrist artery.
Through the wrist?
Yes. So we actually go in through an artery that is in your wrist. So if you take out your hand and you feel your pulse, that pulse is the radial artery. And we actually go in through, make a little tiny incision about the size of the tip of a pen, something you could just put a Band-Aid over at the end. And through that little tiny incision, we go into the artery and go all the way down into the uterine arteries, which are the main supply to the fibroids. And we stop the blood flow to the fibroids and essentially, cut the blood flow off, and they immediately start to shrink. We can take fibroids that are literally the size of like a cantaloupe, or multiple 15, 20 centimeter large fibroids, and shrink them down to the size of a pea by cutting off their blood supply. So a hysterectomy.
Wow. From a cantaloupe to a pea?
Yeah, exactly. And so a hysterectomy involves a big abdominal incision. It's costly, it's painful, and it's more expensive. And when I say expensive, I don't just mean, the dollars and cents. It's also, it takes a high toll on a woman's body. Yeah. It's a open procedure, requires a long hospitalization, usually 4 to 5 days. There are higher risk of complications such as bleeding, infection, damage to adjacent structures. So the uterus, where it's located in the pelvis, is very precious territory. And when I say precious, I mean there are multiple important vessels, nerves, and other structures that are right adjacent to the uterus. One of the most important structures that is at risk for getting damaged during a hysterectomy is called the ureter. So the ureter is the connection between the kidney and the bladder, and it runs right along the side of the uterus. So you can imagine that this delicate small structure can very easily get damaged with a hysterectomy. And unfortunately, and I've seen this happen multiple times, women can end up essentially not being able to pee normally, and they end up with a tube coming out of their kidney and coming out of their back. That's the only way they can urinate. So just
That's
to
terrifying.
illustrate, it is, and it's life-changing, unfortunately. As opposed to uterine fibroid embolization, it's easier, it's better, it's faster, and it's certainly a lot less costly because it's an outpatient procedure. There's no, inpatient hospitalization, etc.
That was my next question. What should the ladies expect in getting a UFE?
Excellent question. So I want to kind of make a point by just showing you pictures what to expect. So when you're getting a hysterectomy done, this is the expectation that a woman should have. So it's a big abdominal incision, and here you can see the uterus, and these ball-like protrusions, these are the fibroids. You can see one here, maybe another smaller one over here. And at the end of the procedure, you have a large incision. As opposed to a fibroid embolization, the expectation is that the entire procedure is done through the wrist, and we use our image guidance, our special X-ray equipment, to look at all of our tools within the body that we're using to get into the blood supply of the fibroids and cutting off that blood supply. So here is a picture of, this is an MRI showing a large fibroid in the uterus. And just to orient you a little bit here, so this is the spine, and this is the front of the patient, this is the back of this patient, and here is the large fibroid within the uterus. And once the blood supply is cut off, the fibroid shrinks down to essentially, something that's not even visible. And the uterus is back to its normal size and its normal shape. So let me show you one more picture here. Let's see if I can advance this slide to give you another. So this is another picture that answers your question, Sandra. So your question was what to expect.
Yep.
This is what you should be expecting. This is your wrist, and this little tiny hole in the wrist that we make to go into the radial artery, that is what you're left with. This band right here, this is a very special band that after the procedure, we inflate this band, and essentially it's a little tiny balloon that puts a little bit of pressure on the wrist to prevent any type of bleeding. And within 30 minutes after the procedure, this band is off, and our patients are able to walk around. They're back to essentially their normal self, eating, drinking, going to the bathroom. And they can even go to the bathroom or walk around with this wristband on. So this is essentially what you should expect. If you're having the fibroid embolization done, this is it. This is pretty much the entirety of the procedure that you'll see, this little wristband and this little incision.
That's a huge difference from the hysterectomy picture you just showed to this one.
Exactly. And again, another thing is that it's a outpatient procedure. What I tell my patients is if you're coming in at 8 a.m. to have the procedure done, you're eating lunch at home. You're home by noon.
Wow.
The entire procedure usually takes somewhere on the order of 30 minutes to 45 minutes to an hour. Usually very, very rarely more than an hour. And the recovery, again, is very short. Within 30 minutes, you're back to your normal self.
And wonderful. And how long before they have to go back? They can go back to work, or is this they can go back the next day, or how does that work?
So that's an excellent question, Sandra. So it varies a little bit patient to patient. What I tell patients is expect to have some pain after the procedure. We'll give you excellent pain medication and a regimen to help control that pain. And for the most part, most women are back to their normal selves within 2 to 3 days. I do tell patients that sometimes it's better to have the procedure done on a Friday so that maybe you're basically ready to go back to work on Monday. But I've had patients who have had the procedure done in the morning one day, and the next day they're back to work. So it just
Wow.
varies from
From
patient to
patient to
patient.
patient.
People who have a little bit of a higher tolerance for pain are able to get back into the swing of things quicker, and others who have maybe a little bit lower threshold for pain, for them it might take 2 to 3 days. But again, nothing like a hysterectomy where people can be out for weeks.
Right. I know I've known people who've had them and it's 6 weeks home.